How to use the mini mental state examination, a guide and teaching resource for aged care service providers. Part 1 in the series of 4 parts: Introduction, what is the mini mental state examination, what are its strengths and limitations. The mini mental state examination was developed in 1975 by Folstein and others as a screening tool to test the cognitive functioning of older people. It assesses orientation, attention, recall, language, and the ability to follow simple verbal and written commands. It provides a total score that places the individual on a scale of cognitive function. It can be used by medical staff, nurses, or untrained staff, with the same score being obtained irrespective of who does the test. It is consistent with the results of other, more time-consuming methods of establishing a score for cognitive functioning. If every answer is correct, a maximum score of 30 points is possible. In its current form, it is largely unchanged from the original that was designed by Folstein back in 1975. It is probably the most widely used tool for establishing a score for an individual's cognitive functioning, and is cited in virtually every research project that attempts to report on cognitive functioning over time or in response to a treatment or intervention. A mini mental state examination score is required as part of the assessment process to determine a person's eligibility for treatment with a cholinesterase inhibitor medication, for example Aricept, Exelon, or Reminol. It is one of the investigations undertaken to assist with establishing a diagnosis of dementia. It should be remembered that the mini mental state examination is not a tool for diagnosing dementia in its own right. The main reason for using the mini mental state examination is to produce a measure of a person's cognitive functioning and to use the results of the test and the score obtained to assist with planning, treatment and care. Repeated testing is done to obtain an objective measure of any change in cognitive functioning over time or in response to a treatment, an intervention or a change of circumstances. The strengths of the mini mental state examination include: it can be administered in 5 to 10 minutes. The equipment required is easily obtained. It is generally well accepted by those being tested. It does not require extensive training to be able to use it accurately and effectively. The same results are likely to be obtained irrespective of who does the test. It provides an objective measure of a person's cognitive functioning. It provides information to assist with tailoring interventions, and is widely accepted and understood by both researchers and clinicians alike. The limitations of the mini mental state examination include: the results are dependent on English language skills. People with a lower level of education may score lower than those with a higher level of education. Sensory deficits, for example hearing and vision impairments, and physical disabilities such as a tremor or arthritic changes in the hands may impact on the score. It doesn't test all areas of cognitive functioning, for example frontal lobe areas. Other parts in this series include undertaking the mini mental state examination in Part 2, Part 3 deals with scoring, and Part 4 with using the results.